Thank you, Chairman, and thank you for inviting me to here, my brother Ömer, and the organizing committee. All inside ACL reconstruction. This is a technique, as you all know, that we open not tunnels but sockets. So there is not a cortical opening tunnel at the end of the opening sockets. Screen. Why to prefer the short sockets or all inside technique? Because we have less bone loss. We open like a 9.5 diameter and like 20-25 millimeters in depth sockets. And then we mostly use one tendon only. With ST tendon, semitendinosus, you can have a graft like 8.59 or more sometimes. Also, then you preserve your gracilis for your additional procedures in your ACL, and there's less morbidity, and you can preserve the muscle strength in the hamstring too. So the graft preparing is like a quadruped graft, and at least we prefer 8, but we mostly have more than 8, and we always leave some muscle on the graft, as my friend Damir Hudas has published it for more stem cells. So we expect less postoperative pain, less hemarthrosis, and lower infection risk with the all-inside technique. And another issue, the most important thing, if you are doing procedures other than ACL, with ACL, combined procedures like HTO, this is a big advantage because you can see the HTO screw there because it's not a tunnel, it's a socket. So under the tunnel, you put under the socket, you can pass your screw and you can even see it. Also, you can protect the physis line, all epiphyseal line, if you can do this procedure in all epiphyseal site. Also, during the tibial fixation, I always consider the contralateral side. Tensioning is very important, and tensioning is very important. If a patient has a hyperextension in the other knee, when you reconstruct the ACL, you should have hyperextension in this knee too. Otherwise, a professional football player, even with 5 degrees of extension of loss of extension, he cannot run and return to the same level. So in all inside technique, it may be an advantage. Tensioning you can consider at the end, even after cortical fixation. So this is several examples from patients. Both knees are doing hyperextension even after ACL. Implant type, it's not like a staple or screw fixation, so we expect low profile implant and small incision and cosmetic, no irritation. Although these advantages, if you look to the literature, in the long term, there are similar clinical results with the standard procedures. But less postoperative pain has been reported. You can check the details in the ISECOS journal. We have published that. We don't call it all inside there, short graft. So what about the surgical technique? The surgical technique, first of all, you do your ACL, you see the footprints of the femur and the tibia. We don't say anymore some landmarks. We always say footprint because everybody's footprints are different and we have to put our ACLs on their footprints and individualizing the ACL surgery. So I will... Okay, after debriding it, we are doing this surgery, opening the sockets like from inside to outside like this, seeing the landmarks in the femur and in the tibia. So we come drill from outside and with opening it inside the joint with a retro drilling system. And you can, a big advantage, you can convergent, divergent, you can open the tunnel and you can arrange the angle of the socket easily with this technique. After opening the femoral tunnel, so coming inside, opening the retro drill, so we open exact average like 20-25 between length tunnels. So go inside, open the tunnel, then we carry our sutures, and then we will open the tibial tunnel, and we have a quadruped graft. This is the tibial tunnel. The trick in here, you have to work the drill inside the joint, not on the bone, because it may be broken then. So you have to also calculate the length of the graft very well, because it mustn't be too loose or too tight. And then after opening the retrograde tibial tunnel, like 20-25, then we pass the graft. Passing the graft, you can see inside the joint all the sockets easily. You can look into the joint, and at the end, we have an ACL reconstruction, all anatomic, all inside ACL reconstruction, without any impingement in extension. This is some remnant of the previous ACL, so stays like this. And the tensioning part, you can tension as much as you can. If the other knee is in hyperextension, I prefer to make the tensioning in full extension, or like the 20 degrees of flexion. In conclusion, all inside ACL reconstruction with short sockets, using one hamstring tendon, and easily individualizing the surgery, and also with advantages of combined surgeries like multi-ligament injured knees, or in the combined, I do a lot HDOs with the ACL reconstruction or revisions. It carries advantages for the surgeon. I would like to invite you also a very nice meeting in Istanbul, 30 November to December, Regenerative Ramos meeting, which I'm the president, for joint preserving, shoulder, knee, and hip joint preservation surgeries. Thank you very much.